Karnataka in 2001, completed fellowship in cleft lip and palate and craniofacial anomalies from CCI Switzerland. Formerly worked in GSR Institute of Craniofacial and Facial Plastic Surgery, Hyderabad, KEM Hospital, Tata Memorial Hospital, Parel. Ex-professor and HOD, Rungta College of Dental Sciences and Research, Bhilai. Currently working at Bhaktivedanta Hospital, Nanavati, Galaxy, and Samarpan Hospital. 20 plus years of academic and clinical experience in private hospitals. Currently working as consultant in oral and maxillofacial surgery and implants in various hospitals and dental clinics in and around Mumbai. He has been awarded with the landmark Rutherford Research Award in 2015, published multiple research papers in national and international journals. Now I'll hand over the rest of the meeting to you, sir. Sir, please. Sir, you're not audible. So you can unmute the mute button.
Am I audible now?
Yes, sir.
Yeah. Okay. So thanks for the introduction, doctor. Good afternoon, everyone. My today's topic is surgical complications in implant surgery. So I'll be talking only on surgical complications. You can hear me? I can go ahead, doctor?
Yes, sir.
Yeah, okay. So this is the basic skeleton of my seminar or the topic. I'll be talking on introduction, definition of the complications, clinical cases, which I have my own few cases and others cases, recognition, management, and prevention of complications, and finally, conclusion and recommendations. Implantology is an ever-growing field. When I was doing my post-graduation or graduation, implant was something extremely new thing. Now, almost every clinic, in every clinic, they are doing implants. So routinely, people are placing thousands of implants now, and implant is a very routine practice. So that is why we should know about the complications associated with implantology. Nevertheless, it has, as every surgical procedure, several complications that can occur and that must be known in order to prevent or solve them. So complications are very important. Nobody likes complications, but complications are very important and we are supposed to know. That is why I'm talking about complications. This is a very important line which I found somewhere and I just, was very fascinated to place this line here. Only surgeons who do not operate have no complications. So there is no surgeon on the earth who will say that, oh, I had no complications. I am complications free. No. Complications is part and parcel of every surgery. So those who operate a lot have few complications because those are experienced surgeons. So they can minimize their complications in comparison to those who operate little. If you do very few cases, obviously the complication rate in your practice will be higher. So if you do more cases, you know the anatomical variations and you are able to manage the complications and you can definitely minimize the complications. Obviously, complications are very unpleasant. Nobody likes complication, but unfortunately, we have to face the complications. They are unpleasant for the patient and even the doctor. But we have to take it as a lesson. We learn from these complications and we have to obviously learn from our own mistakes and others' mistakes also. So complications should be taken actually positively and we should discuss with our friends also. So we can, in a group, we can definitely grow and manage the complications and minimize the complications better. Apparently, one should make mistakes first. So if you don't make mistake, you're not going to learn from your mistake to become an experienced dental professional or any other professional for that matter. So perioperative complications are few actually, but they are unreported in the literature mostly. The complications basically are minor, major, and life-threatening. That is a big problem. There are few life-threatening complications in oral surgery or implantology. So some complications are considered as surgical errors like malpositioning or nerve injury. These are preventable. If you do pre-operative proper assessing, CBCT and clinical examination, malpositioning and nerve injury can be prevented to great extent, but still it is unavoidable sometimes. But we can be at least careful pre-operatively and intraoperatively and even post-operatively. So the complications can usually occur because of insufficient pre-operative assessment and improper planning. So now we have digital data available. We have almost virtual planning available. We can use the DICOM files to great extent, and almost we can do virtual treatment planning as if the patient is with you. You can have the models, we can have splints. So we are in a better position now. But no doubt we have to improve our skills. Skills are very important. Technology is important, no doubt, but poor skills cannot be combined with a good technology. Good skills are important. So continuous education is important for our dental profession. So you can do number of cases, but at the same time you have to improve your skills. You attend regular seminars, you attend regular conferences and workshops, and we can improve our technique. We can learn from others. So what is the complication, or what are the surgical complications? Complication is unintended, unwanted, and unexpected adverse event caused by surgical intervention that may present itself during the procedure or after the soft tissue healing. Unintended, unwanted, unexpected, but not unknown. Unexpected, yes, possible, because yes, if you are not aware of, if you have not read about the things, or you have not discussed, or if you are less experienced, but it is not unknown. Complications are almost unknown. The complications are given in the books. All the possible complications are almost there in the literature. So they are not unknown. So what are the reported complications? Malposition and displacement of implants. That is what we see regularly. So we can actually have a collision with anatomical structures or the adjacent structures, or displacement of the implant into the sinus, or sometimes rarely into the different spaces like a temporal space or submandibular space, sublingual space, or the implant can be displaced into the body of the mandible. I will be discussing all those types of complications further. There is a possibility of edema. Edema usually is postoperative edema, and it is common after every surgery. So edema is usually self-limiting. You don't have to treat it. Really, it is conservatively, it is managed, and it usually vanishes over a period of time. Hemorrhage, yes, hemorrhage postoperatively, intraoperatively, it is there possible, and sometimes it is an emergency, or sometimes it is life-threatening. You have to take the patient immediately to the operation theater or to the hospital as fast as possible. So that is extremely rare, but yes, life-threatening hemorrhage is a possible complication in the implant surgeries. Nerve injury, mostly it is associated with inferior alveolar nerve, very rarely to the other nerves like lingual nerve or any other nerve, but usually we see nerve injuries in implant surgery pertaining mostly with inferior alveolar nerve. Mandibular fracture is possible in atrophic mandibles, especially edentulous mandibles, where we see the patients have paper thin mandibular basal bone available. There is no alveolar bone, and especially when you are placing the implant between the two mental foramen, and if we do some excessive pressure application or too much of drilling, there is a possibility of mandibular fracture in edentulous mandible. Infection and delayed wound healing. Obviously, we have to follow strict asepsis protocol, sterilization protocol preoperatively and intraoperatively. And there is a possibility of delayed wound healing, which can be because of the patient's factors also, when the patients have some comorbidities. So malposition of the implant is very most frequently seen in as an intraoperative complication. So where it can be possible, especially in the anterior region, the severity of this complication varies depending on the degree of malposition, three-dimensionally. Usually, when we take X-ray, we can see the only two-dimensional situation there. When you take a check pre-op this thing X-ray before placing the implant, so we may have a parallel. In this case, on the right side of the screen, if you see the implant placed is too much labial. But if you take an X-ray in such situation, you will get it is as if it is straight away parallel to the adjacent tooth and nicely parked between those two teeth. But three-dimensionally, we can go very much wrong, and then it is challenging for the prosthodontist to manage. So especially in aesthetic zone, it may lead to unsatisfactory results. But in such cases, the prosthodontist can manage it by changing the angulation of abutment, or he can use castable abutments. Most frequent reason is incorrect angulation of the drill. So when the drill is done, drilling is done in inaccurate direction, you get such type of results where you are not happy with the placement of implant pertaining to the angulation. So again, insufficient preoperative planning. So you have to plan preoperatively, three-dimensionally on the CBCT. If you don't do it properly, obviously there is a possibility of this type of a complication. Inappropriate instrumentation. So you can have series of drills, and you can take multiple X-rays. Nowadays we have RVGs, so we can take multiple X-rays. In a doubt, you can always change the direction. So inappropriate instrumentation means you use a proper instrumentation during the procedure. And obviously, in some complex cases, especially if there is a less space available between the two teeth and it's difficult for you to manage, you can use surgical splints, but you cannot straight away rely on surgical splints, obviously, but they are obviously guiding you. You can use them as a good guide. And again, obviously, you have to have your own tactile sensation, and you can take frequent X-rays and make sure that your implant is properly placed. You can change the angulation before placing the implant. Means after all the drilling also, you can change the angulation of the implant. So especially when there is a less intraradicular space, when the roots are converging to each other, it is difficult for you to place the implant. So here you can use narrow and long implants and take multiple X-rays. In the X-rays, sometimes you feel one side the implant is overlapping with the adjacent tooth, or it's probably touching. You change the angulation, keep the drill, check drill there only, take in different angulations, and you will come to know that it may not be very close to the adjacent tooth. So you may not be damaging it, but one X-ray will show that you are touching the adjacent tooth root. And if you change the angulation, you may see, oh, there is no problem, you are quite far. Especially this happens in the area of canine and premolar region. That area is very crucial. So when the implants, like on the right side, if you see the implant is too much angulated, and it is managed very nicely managed prosthetically. So here you don't have to take out the implant. So prosthetic correction with angulated or individualized abutments, it is possible to manage. Or in some cases, you can obviously do additional hard and soft tissue augmentation procedure. You can remove the implant and do regraft the implant, place new implant also. It is all possible. You can take the decision, but once the implant is integrated, and if possible, prosthetically, you can easily manage the implant. You can see on the X-ray, it is nicely managed. Now, in such cases, yes, if it is integrated, still it is possible to manage prosthetically, but it is not the ideal placement of implant. So in such cases, we have to be very careful. Otherwise, it is challenging prosthetically to manage such implants. Sometimes here the surgeon has wanted to avoid the entry into the sinus. So he has placed the implants tangentially. The anterior implant is absolutely not touching the root canal tooth. The posterior implant, if he wanted to place it straight, probably he would have entered the sinus. So to avoid that, he has just placed it in the angulation so that he can have a longer implant inside. And it is manageable. It is definitely manageable, but challenging prosthetically. So displacement of implants. So This is again intraoperative complication, which is commonly seen, mostly seen intraoperatively, sometimes postoperatively. So most often the implant just slips into the sinus. What is the risk? We know what happens to the sinus. Once the tooth is lost, there is a loss of bone. Bone loss is there in terms of width, especially maxillary posterior region, width as well as height. But there is additional problem in the maxillary sinus area. The maxillary sinus starts pneumatizing. So sinus comes down, bone goes up, and there is a width loss also. But width usually is not a problem in posterior maxilla. Height is a problem. So we don't have a native bone, adequate native bone. That is one problem because of effect of additional sinus effect, pneumatization, and the bone itself. Now the quality of the bone is also bad. It is a D4 bone. As we know, D1, D2, D3, and D4 bone. D4 is very soft bone. It is the softest bone which is present in the posterior maxilla. And the density of the bone is less here. So failure rate in this area is more. So here we have to do less preparation. Like inadequate preparation is very important here. Sometimes if you prepare ideal, there is no hold, there is no primary stability in the implant. So we have to be very careful when you are placing implant here, because the implant itself can expand this bone because it is very soft. So use expansion in maxillary sinus area rather than cutting. Don't use the drill straight away. Maybe first or second drills you can use, and then you are supposed to use the elevators, expanders you should use, where expanders are the compactors. So you are compacting the bone, so the density of the bone reduces. At the same time, you get a good place where you can place the implant, and you get a very good primary stability. So we have insufficient subantral bone quality. Quality is bad because it is a D4, and quantity because width and height is, especially the height is less. So usually we have very less height in the native bone. Transalveolar sinus floor elevation, that is Summers technique, especially in indirect sinus lifts where we use Summers osteotome. Then we break the bony sinus floor. And when we try to place the implant, and if you don't get adequate hold or primary stability, the implant can suck into the sinus. That is a very known complication, real known complication post sinus lift, especially indirect sinus lift. Because in the direct sinus lift, we have a direct sinus lift, we do lateral window approach, and we see the implant entry and everything directly. So even if there is a slippage of implant, you can retrieve the implant easily. But in indirect sinus lift, as you have not reflected that area, the implant just slips into the sinus and then it floats into the sinus. So how to prevent this? Pre-op imaging, pre-op sebacity of that atrophic maxilla is very important. We have to assess the quality and quantity of the bone, and we should know how much is the native bone available, and then you can plan it. Improving primary stability, as I told you, condensation of the bone is important. As the bone density is less, you condense more bone, you expand the bone rather than cutting. So there is no bone loss. Whenever you are expanding the bone, there is no bone loss. You are compacting and increasing the density of the bone. And tapered implant. So tapered implant means you will have a good hold at the crestal level of the implant. That area is soft. So tapered implant, minimal preparation, and place the implant. And a good primary stability is important when you are placing in this area. If you have any doubt, if you're not sure whether you have punctured the sinus, bony sinus wall, floor, or the sinus membrane, don't place the implant. Just defer it and do it as a second stage procedure. There is no harm in doing that. If you're not happy, or you can use, if the implant is just going in, say, 10 newtons, or 4 mm implant, use 4.5 or 5 mm implant. You can let that implant go for waste, and you can try the thicker implant and see whether you are getting a good primary stability. Still, if you are in doubt, just do the procedure later. So these are a few cases which I have managed. On the left side, if you see, it's a conventional implant, which is again same procedure. In indirect sinus lift was done, and when the patient was called for a healing cap placement, the implant was here into the sinus. IOPA, initially the doctor took IOPA. IOPA, there was some visibility of implant, but he could not get the deep IOPA, and he had a facility of OPG in his clinical setup, so he took OPG. So that implant I had to remove surgically. On the right side, if you see the basal bone implant, so again same problem. The doctor wanted to engage the other side of the cortex, but he could not, and the implant slipped. Once it slips inside, it just goes into the sinus. Sinus is a hollow cavity, so it just goes inside, and then it is not. And especially these both the cases, like on the left side, hardly any, means one simple reflection the doctor must have done, and on the right side it is flapless. So if you do flapless, obviously the implant will go into the area where you cannot see anything. You just come to know that the implant is vanished into the sinus. But then obviously you need to retrieve this implant, or both implants retrieval was like, I had to do cardiac tube operation, and I removed those implants from the maxillary sinuses. Implant can go somewhere else also if your technique is improper. I don't know where this doctor was trying to place it. On the left side, if you see, that is probably a conventional implant. It's gone into the temporal space near the coronoid process of the mandible. So it was not palpable much there, but retrieval of this implant was difficult. On the right side, this is the very old case of mine where the dental surgeon placed implant, and see here also CBCT sometimes doesn't reveal the details. So whenever you are placing, when you are doing the osteotomy or the drills, if the bone is soft, always under prepare. Don't have ideal preparation. Various systems have various preparations, and drilling beds are different. They have their own planning. So I will not go into the details, but if you do inadequate preparation, there is no problem. You can always take out the implant, keep it properly, don't touch anywhere. And additionally, you can increase the length or width of the osteotomy site. But don't always it is okay if you are going ideal way, but after second or first or second, maximum third drill will understand that this bone is not the way it is supposed to behave. Especially now, this is the mandible on the right side, IOPA. Here, the doctor did ideal preparation, normal regular preparation. He did crestal preparation also. Crestal drills are available in most of the kits, and it was ideal. So when he placed the implant with the machine, he placed with 20 newtons. So if the implant is ready to go in 5 newtons, it will go in 20 newtons also. So he was not aware about the primary stability. So he thought the implant is gone into the bone properly. I have done ideal preparation, and when he tried to place the cover screw, this implant was just snipped back inside the mandibular body, and then it was difficult to retrieve. Obviously, he was trying to search it. It was further going inside the marrow of mandible. So this is one complication. Similarly, you can see on the left of your screen, again the one implant is gone into the maxillary sinus region. Same story. Then we have to take it out by Cordell loop operation, and one on the right side, you can see it is gone into the mandible. So retrieving this implant is very difficult. If you retrieve, you are going to at least cut the cortical bone. So buccal cortical plate will go if you take out this implant, and you have to take out implant because it is very close to the nerve. Also, you can have neurological damage. So you can take out this implant, and you can replace it very carefully, anterior or posterior to the old site. The implant can go into other spaces also. So if you're not careful, in this case, the implant is gone into the submandibular space. Submandibular space means it is just below the mylohyoid attachment. So if you are not careful, you can perforate the lingual cortical plate. And if you just blindly place the implant, it can just go into the submandibular space. And if this implant has to be removed, sometimes it is difficult to remove intraorally. You may have to give extraoral incision and take it out. This can lead to complications like submandibular space infection, Ludwig's angina, and so on and so forth. So these are all difficult cases to manage. Again, for these complications, once they arise, again, we have to assess it, how to remove it. And sometimes it is not possible, as I told you, to remove it intraorally. you may have to employ extraoral approach and you remove this under general anesthesia. So about edema. Edema is one of the known complications. Almost every surgery will have some edema. Why there is edema? Swelling is noticeable after 24 hours after performing the surgery. The causes are wide flaps. Yeah, when you reflect more and if your handling is not proper, the swelling, even if your handling is proper, obviously the wide flaps can definitely cause post-operative swelling or edema. Bone regeneration techniques, where you use artificial bone, the body can react to those artificial bones and you can have good edema or swellings post-operatively. Patient definitely complains of swelling. I have seen, especially in the direct sinus lift cases, the swelling is massive and sometimes it just goes below the infraorbital region and the patient complains of the swelling and he says, oh doctor, what has happened to my eyes? Actually there is no problem, it is just a swelling. We have to just assure the patient and we have to manage. Sometimes prolonged surgical time, yes, we do multiple cases, we can have multiple implant placements and we have prolonged surgery. There is a possibility of edema. So what happens? The edema leads to trismus. There is a lack of hygiene in the wound and there is a discomfort to the patient. So that adds to the problem. It decreases with time and obviously it vanishes in a few days. How to manage? You have to just carefully ask the patient to, we have to carefully manage the soft tissues. When you are retracting, we have to be careful, we have to be meticulous. We always say you respect the tissues, you are respected, especially the soft tissues. Soft tissue handling is important. So you have to use good sharp blades. If you have any doubt, you can change the blades. You can use multiple blades, sharp blades, good quality blades, good quality instruments, sharp instruments, and even the mucoparietal flaps, they should be reflected very nicely from the bone without causing any tear. If you have a problem of reflection, you're not sure about the exposure, give wide releasing incisions. Follow the protocol of flaps. Give a broad base and reflect nicely. That will reduce the edema. Cold pack immediately after the surgery. Ask the patient to apply ice from outside, and that will definitely reduce NSAIDs and even the corticosteroids. You can give intravenous corticosteroids, or even in the area of the surgery, you can give corticosteroids. Some people prefer oral corticosteroids to be tapered, obviously. You can give. So sometimes you have massive edemas like this, or buccal edema on the left side, orbital edema on the right side. I think on the right side, multiple implants were done, especially in the canine region. So in the canine region, a longer implant, when it is used, orbital cellulitis like this is possible. Not to worry, we have to assure the patient that I have not done there anything. Your eyesight will be absolutely normal. Just wait and watch. It is just self-limiting. It will vanish in few days. Ecchymosis and hematoma. So you can have ecchymosis like this, especially in elderly patients where, especially in the mandible region, when you are working between the two mental foramina, most of the time, not always. Obviously, ecchymosis is possible anywhere on the face. Even if in upper implant cases also you can see ecchymosis, but you have to assure the patient. Female patients can easily manage this with some makeups, but it is self-limiting. There is no need to apply anything in that. It is seen in first few days, and later on it resolves on its own. We don't have to treat this. We have to reassure the patient and tell the patient that every case is different. The patient may compare your work with other doctors' work, like, last time this doctor did this and there was no, this is something visible outside, people are asking me and all. You have to just reassure the patient, and that's it. It is self-limiting, nothing to worry. Sometimes upper implants, you can see this can happen. We have to assure the patient not to worry. This was one of my cases where I had to manage the bleeding. This was obviously very challenging case and very rare. This case report was published 2 years back, 2 or 3 years back by me. I am the first author of this article. So after implant placement, if you see on the right side, there is a scan seen and few implants are placed. These are all basal implants. I'm not saying basal implants, because of basal implants it has happened, but basal implants, their drills are long and the implants themselves are long. And here This lady has an atrophic maxilla. So hardly there is any length available. So if you use long drills, there is a possibility of bleeding in the maxillary sinus area. So when the patient had gone home back, this was the situation. She sent this photo to the concerned implantologist, and the patient was referred to me. The patient was getting bleeding from the nose, and that particular side, right side, there was a fresh bleeding. In the mouth, there was no bleeding because this was a flapless procedure. So I'm not against flapless procedures. Flapless procedures are good, but these things rarely can happen because it is a blind procedure. You are just placing something inside and there is no direct vision. When you open the flap, the bleeding, if the surgeon had opened the flap, he would have seen the bleeding intraoperatively only. The bleeding was not massive per se, but with this, the patient was in panic situation. We admitted the patient in the hospital. We managed. I'll tell you how I managed the procedure, managed the complication. But this way, there was no intraoral bleeding possible. So the sinus drains through the nose. So that is the only drainage possible through the sinus. So the blood, whatever was collected in the sinus and above the sinus, actually the sinus wall was bleeding where the drilling was attempted. Implant was not placed into that drilling area. So that bleeding was continuous and slow. So what happened? The bleeding, the sinus was full of blood. Next, the nasal cavity, means the sinus was draining through the nose. So nasal aperture, especially on that side, was blocked. Nasopharynx was blocked, but the bleeding was still on. So what happened? There is a nasolacrimal duct. So because of the capillary action, the fresh blood was with capillary action. It came into the eyes. So it was as if there is eye bleeding and fresh eye bleeding. So patient got panicked. So that was the situation. So we took the patient to the operation theater. I thought of managing it under local anesthesia. I could successfully manage it by doing a Cardwell loop operation. I had to clean everything. We took all the investigations, blood investigations, because I wanted to rule out any hypovolemic shock. I don't know how much volume is lost. So I did that. Unfortunately, there was no problem. We opened the sinus, and there I used the cautery. I saw a bleeding spot. So after cleaning everything, that bleeding spot I could locate. I cauterized that area. We checked the patient again for 15 minutes. We waited. We asked the patient. Patient was conscious, obviously. So I asked the patient whether there is any collection of blood inside the throat, because nasal cavity and everything was visible to me. So throat, there was no problem. She said there is no collection. So there was only one bleeding spot. So I wanted to rule out all the spots. There was no problem. Sinus was clear because I opened the sinus completely by Cardwell loop operation. And the patient we discharged the patient on the next day. So we have to be very careful about the nasolacrimal apparatus. It is very close there when we are placing the implants, because there is atrophic maxilla. So there is hardly any space between the orbital floor and the maxillary sinus alveolar area. So there is hardly anything. So we have to be careful while using the long implants. For the basal implants, nasal bleeding is an indication of engagement. So that is also misleading. So when there is a nasal bleed, in the basal implantology, obviously that is an indication that the implant is gone to the other cortex. So that was also misleading in this case. That is why the patient was asked to go home, because this bleeding was normal. The nasal bleeding was normal in basal implantology. This was just after a few days, because they in the basal implantology they complete the case in 72 hours. So this was the situation after 3 days, even after the patient was discharged. This was done, and in 3 to 4 days, the case was completely rehabilitated. Again, one more horrendous complication, very dangerous and life-threatening. You can see what is happening here. The tongue is raised up. Some sutures are seen, and you can see the floor of mouth is raised. So this is most dangerous. This is because of lingual hematoma. It happens when we are operating in the anterior region between the mental foramen. So we have to be very careful in this case. These are usually seen in edentulous patients, obviously, means full edentulous patients, atrophic mandibles. So here, normally, that is why I say don't, you can rely on the splints, but I feel you should give incision and reflect of, once you give a good crestal incision, you stay on the bone and reflect it nicely. As long as you are on the bone, you are safe, because on the bone, there is no vessel which you will encounter if you are staying on the bone and working on the bone. So reflect buccally, reflect lingually, keep the retractors on the lingual side, protect the lingual cortical lingual area. So if you are placing, you are drilling, if you perforate the lingual cortical plate, you are protecting the tissues by the retractor. Your drill will hit the retractor. So there is no chance of you damaging the arteries in that area, because those arteries, they in the edentulous area, they lie quite superficial, and there is a high chance if you are not proper into the angulation and if you perforate the lingual cortical plate, immediately next to that there is a vessel. There are two main vessels which are there, but you can use guide, but still after using guide, what I do is I open that area, reflect it, put a periosteal elevator or a broad elevator or a tongue depressor between the bone and the mucoperiosteal flap, and then I do the osteotomy. Then it is like, even if you go blind, there is no problem. You can change the angulation. You are completely protecting that area, and there is no chance of damaging the vessels in that area. So on the left side, you can see we have in the sublingual region, it is a dramatic presentation. You can see the sublingual artery is just above the genial tubercles. So you can palpate the genial tubercles clinically. So you know how much up you have to be. You have to be careful in that area. So you can palpate genial tubercle. You can have a total idea of lingual sulcus or any undercuts in that area. You can palpate with your finger and correlate obviously with cibicity. And you palpate genial tubercle, so you know their muscles are attached here. And sublingual artery is superficial, which is a branch of a lingual artery. So that we can damage first. And then there is a mylohyoid muscle, and below mylohyoid muscle, we have a submental artery. So that is a branch of facial artery. So if we damage this, and if there is a hematoma, sublingual hematoma, the tongue will be raised, and that is definitely an emergency situation. And then we have to take it as an emergency. On the right side, you can see the muscle attachments and the course of these two arteries, sublingual and submental arteries. So because when the patient has teeth, the angulation or the bone is different, but as the age advances, there is a resorption of bone, and as it progresses, you have no alveolar bone available, and only the basal bone is available. So there, the obviously genial muscles are very close to the crestal part. Right now, in this case, still the genial tubercles are quite below. So and you have to the angulation of the drill also, or the implant is important. You can slightly angulate lingually, so that means the head of the drill, head of your handpiece, if it is slightly lingual, implant will go more buccal. So there is a less chance of perforating the lingual cortical plate. Even on the lingual side, lingual concavity is seen in the region of canine and molar region. So you can correlate with cibicity, and many a times they give measurements up to the lingual concavity. So that you can palpate and you can assess with cibicity, and that way you can change your angulation, and you can obviously think about the length of the implant, future implant to be placed. So how to manage these complications? You have to be aware about the changing anatomy of the mandible. The mandible with teeth immediately after extraction, as the age advances, as the patient is wearing dentures for a long time, it will be definitely changing. There is a different blood supply also. We don't have much blood supply. So you have to understand the changing anatomy or the resorptive pattern of the mandible, how the mandible resorbs. Preoperative clinical examination, palpation is very important. So with finger palpation, you should palpate the lingual and the buccal side, especially the lingual side. So you can palpate the mylohyoid muscle, attachment of the mylohyoid muscle, genial muscles, and you can assess it. And obviously preoperative imaging, cibicity, combination with palpation, clinical examination. Obviously you are in a better position if you do this pre-operatively. Sometimes the positioning of the implant is of the patient is difficult. Like all of us do implants in the on the chair. The patient is sitting on the chair. But sometimes if the patient has to be planned under general anesthesia, we don't have these chairs in the hospital or operation theaters. So there the patient is completely lying with the extension, or it may not be with extension, but at least the patient is flat lying. So you have to manage there. Placing lower implants are also difficult in such situations. So there, the angulation, your working style has to be totally different, because the patient's position is completely horizontal or the patient has extended neck. So that we have to take in mind. So we should usually have orientation of landmarks rather than the patient's position. So if this happens, especially when there is a hematoma happening in the submandibular area, we ask for the medical emergency, transfer the patient to the emergency department immediately. So don't do anything. Treat first what feels first. Don't do anything. Just take the patient, call emergency, apply compression, press that area, and obviously don't take out the implant. Just take the patient as fast as possible to the emergency room or emergency department. As all of us know, airway, breathing, circulation, and disability, and finally exposure. Exposure means we have to expose that area. Basically, airway is important. Once you have maintained the airway, everything will fall in place, or you will have some breathing time. As a doctor, you will have some time to manage this patient. You can speak to the medical professionals, and you can take the patient. You can assess. The sisters and doctors are there to help you out. They will start intravenous IV line. Even if there is a blood loss, blood can be given fast. Patient will not go into hypervolemic shock. The patient has to go to the higher center as fast as possible. Airway has to be maintained. If you're not able to maintain the airway, then we can lose the patient. So close observation of the patient is important. If the situation is like this, you can see on the right side, the tongue is completely obstructing the airway. You can see the hematoma in the submandibular region, and tongue is completely obstructing that area. And obviously there will be, you have to see for the oropharyngeal region. You can press the tongue and see what is happening in the oropharyngeal region. Because if that is, there is a edema in or hematoma in that area, the patient will not be able to breathe. And if there are any vocal changes, when you talk to the patient, there is some change in the voice that indicates that there is some problem in that area, and you don't have enough time. We have to take the patient as fast as possible to the emergency room. There are few airways which can be used. Yeah, Goodell tubes are there, or simple oropharyngeal airways can be used for this. We should have in our dental unit. So in case it is easy to place, you just place it into, so that the tongue, this doesn't allow the tongue to go superiorly, and oropharyngeal area will be open for the breathing, and the patient can breathe even if the tongue is trying to go up. And you have some time to manage the patient or to shift the patient to the hospital or emergency. So what is important is you have to be aware about potential life-threatening complications. We should know how to handle the complications, or at least initial management, and obviously then there are better people to manage. So first priority, as I told you, secure the upper airway tract. If the patient is not able to breathe, then you can't do anything. Try to stop bleeding by compression. So if there is a hematoma formation, press that submandibular area hard, so that the blood vessel will be pressed. So there is a vasoconstriction, and the hematoma will not be allowed to increase in size. So you have time to manage. Never remove the implant which is inserted, because that can lead to more bleeding, because at least it is obstructing something. If you remove that, you will allow that flow to have a free flow, and the patient can bleed to death. So never remove. Do not drain, because if you try to drain, it is actually the hematoma is expanding. So if you try to drain, there are big blood vessels. They are just going to pour out blood, and it is not going to help you out. So don't drain now. Drainage can be done intraoperatively when the patient is shifted to the higher centers, and the patient should be transferred to the nearest hospital. So whenever you are doing anterior mandible, if you are not sure, keep oral surgeon around. I'm not saying you don't place implants, but the oral surgeon should be easily available, or he should be handy, or you keep him around, or place place implant with him. Just know the complications there, and obviously have knowledge about your nearest hospitals and the surgeons and their timings. Do these cases obviously in the morning hours, and if there is any complication, you should be able to contact the concerned person as fast as possible, and you can take the patient to the hospital. These are extremely rare complications, but these are obviously lethal complications or life-threatening complications. Nerve injury is the next complication, which we see often. Most of the times it is avoidable because we have CBCT in our hand. Now, when I was a student, there was no CBCT, so we used to have so-called 1:1 OPGs. So they say 1:1 means it is as it is in the mouth, but still we have to be safe. So for the X-rays, the safety barrier is different, and for scans, it is different. I will be coming to that. So nerve injury is very common. As I told you, or only inferior alveolar nerve is almost 100% inferior alveolar nerve is injured. Means these other nerves like lingual nerve or infraorbital nerve, they are injured less because they are not that proximal, and we always see the cases with this type of nerve injuries with inferior alveolar nerve. So as all dental implant surgery, it is elective. So we, as the procedures are elective, they are preventable. So here you can see the implant is just sitting on the mental foramen. The nerve is down, but unfortunately the mental foramen is up. So because of this misleading situation, even if you take IOPA, probably with that two-dimensional way, it may show it is away from that. Sometimes CBCT report maybe not that right. Like if the available height is say 8 mm, and if the measurement is wrong by the radiologist by any means, there is a marginal error possible. So if they say 10 mm, you have to be very careful. You can take multiple X-rays. And in this case, the implant was removed, patient was comfortable, and later the shorter implant was placed. The mental nerve, many times it comes out of the foramen, but it has an anterior loop and before exiting from the mental foramen. So that obviously is seen in CBCT, but sometimes we don't take CBCT and we place implant. The loop has to be taken into consideration while placing implant. So if there is a loop, you have to find it out, or else stay away from the loop and be safe. So almost exclusively, as we see, inferior nerve is damaged. Other nerves are very rare, and this complication is also very less rare, but it is a severe complication. So you can have post-operative neurosensory disturbance, which is caused by sometimes even the local anesthesia can cause this thing, paresthesia or anesthesia by needle penetration. The needle bevel of the needle also, when you inject proximal to the nerve, we can directly damage the nerve by needle injury. So it is not pertaining to the implant surgery, or even cytotoxicity of the local anesthetic agent. That also can cause damage to the nerve, but usually it is self-limiting. Later the patient is comfortable. Sometimes when we retract, especially the mental nerve, when we retract, we see if the retraction is too hard, we see the nerve is thinning down. The neurovascular bundle is thinning down. So there we have to be careful. You need to have good flaps, and the retraction should not be improper. So there we can manage the retraction. If it is proper, the nerve damage is less. Drilling procedure. If the depth is too much, or there is no proper coolant used, usually they say you use cooled this thing, saline, always better. You should have a very good coolant. Even in the anterior region of the mandible, where the bone is D1, it is hard bone. So there you have to be careful and use a good cooling system. The irrigation is very important. So you don't have to stay in the bone for longer time. But in this case, the depth is important. If you are in a doubt, just take one X-ray with that particular drill or paralleling pin and make sure what is the length. If you are in a doubt, take X-ray, always better. So sometimes there is a possibility of compression from implant or intraosseous bleeding or inflammation. The canal is always, in the canal we have neurovascular bundle. So the vessel in the canal can bleed and can cause compression, or an implant directly can cause compression on the nerve, and the nerve inflammation also can cause neurovascular neurological symptoms. There is a possibility of direct trauma. So if we drill directly on the nerve, the canal will, beyond the canal, we can just transect the nerve. There is a possibility of partial or total transection of the nerve. So how to avoid? Basically, we have to tell the patient, because patient is not aware. Nobody tells the patient. I have seen. So always in the informed consent, include the nerve injury. Include nerve injury as a part of, especially for the rollover one. And if the patient asks you, you have to explain what do you mean by nerve injury. Explain the patient between the sensory and motor nerve difference. Patient may feel, oh, my nerve, if it is damaged, my mouth, there will be a deformity on my face. But you have to explain the patient that there won't be any deformity. Only you will know that there is a problem of some nerve. Your lower lip will be numb, partially numb. There will be a partial loss of sensation, and it will be a transient mostly. So that you only will know. There won't be any. It is not a facial nerve, which is a functional, which is a motor nerve. So there won't be any functional problem. Only you will know that there is a loss of sensation. So second point is, if you train the dental professions, if you have many workshops, and if you train the dental professions and make them aware about the complications, and all, the more they do the procedures and use the technology, obviously the nerve injury problems obviously can be reduced. Sometimes we have these procedures of nerve bisecting the nerve, nerve bypass procedures, where the implants are longer and you bypass the nerve. So there we have to be extremely careful. So if you do nerve bypassing, immediately after the procedure, we should take CBCT. If there is any if the implant is in the close proximity of the nerve, the implant can be removed and replaced somewhere else. But if it is prolonged, obviously the injury can become a permanent injury. Intraoperative technique is important. We have to assess, and intraoperatively we have to be careful. I always feel that you should have stoppers, because the markings are, you cannot have control on markings. But if you have stoppers or stopper kits, especially the guys who are new in the implant surgery, they should use the stoppers, especially in challenging cases. When you have a very good bone available, say more than 10, 12 mm, then nothing to worry. But if you have a small, very less height, use stoppers, so that inadvertently also, if you press that area forcefully, if you try to drill, you will not damage the nerve. So initially better to use stopper and be safe. If they are showing you, say, 8 mm, start with 6 mm, take one X-ray and then go beyond that. Post-operative care is important. If there is a damage, you take immediate X-ray or a scan, make sure what is the situation. If the implant is very close to the nerve, obviously you can remove it. Or if it is not close and you know that it is just because of the drill it has happened, you just assure the patient and treat the patient medically by giving corticosteroids. So preoperative imaging. So we need to visualize where is the mandibular canal. That is most important in mandible. So as I told you, in OPG, safety distance is 3 mm or more than that. So that way, even if it is so-called 1:1, you measure it with the scale and you stay at least 3 mm away from the canal or the mandibular foramen. And CBCT, it is 2 mm. You have reports in your hand, but still you exactly don't know which slide you are watching and which place you are trying to place the implant. So maybe you can correlate, and you yourself can have DICOM files and the softwares nowadays available. The softwares are there. There you can check yourself and reconfirm about the length and the width of the available bone. So as I told you, planning softwares are available. So nowadays we use softwares to confirm about the situation out there. So we'll come to know what is the actual position of inferior alveolar nerve canal, drill guides may be helpful, but not trusted blindly. So if someone is giving you drill guides or the splints, you cannot straight away rely on that. You have to assess your own case and plan the case. This is most important point. Whenever placing implant, never give nerve block. Always give infiltration. Why? Because if you are proximal to the nerve, when you are drilling and if you touch that area just near, what will happen? There will be sudden pain and shock during the bed preparation. Initially, when you are preparing the osteotomy site. And when you touch the neurovascular bundle, there will be profuse osseous bleeding. That means, as I told you, it is a neurovascular bundle. There is a nerve down and vessel up. So when there is a bleeding, that means you have touched the neurovascular bundle. That is why there is a profuse bleeding, and you take a radiograph. You keep a depth gauge or whatever, the same drill, whatever you have used, and take the X-ray. In doubt, you can just don't place the implant, and you can do it after 2-3 days. Most important point, many of the situations, drill length is not equal to implant length. So if there is a planning given by the CBCT that 4x10 implant you are supposed to place here. So if you are using the 10 wala drill, the 10 drill may be slightly longer than the implant length. So that you have to keep in mind. Postoperatively, early postoperatively, we have to check the patient for 6 hours. Ask the patient whether the anesthesia is totally gone or you are feeling some numbness in that area. If the patient has any signs of neurosensory disturbances after local anesthesia is gone, recheck postoperative radiographs to be taken, or even you can take CBCT. Consider withdrawal or removal of implant in 36 hours. If in 36 hours, before 36 hours, like in almost 2 days time, if you don't remove, then there is a chance of long-term neurosensory deficit, or it may be permanent then. Then later, if you want to remove the implant, it may not be helpful. So just a demonstration like this. These are the drills. Their length may be slightly longer than the particular implant. So mandibular fracture is also one of the complications, extremely rare, but it is a very serious complication when the mandibles are extremely resorbed, like Kwood 6 and 8. They are resorbed mandibles. So how you can manage, how you can prevent? Use a shorter dental implant. It may be appropriate. Use a small short implants. Assess the mandibular height and width pre-operatively. Do minimal traumatic surgery. This is a D1 bone. If you use pressure in a thin pencil-sized bone mandible, it is going to create too much of heat. And if you apply too much of pressure, and the bone is, obviously it is a D1 bone, so you have to apply some pressure. You have to be extremely careful. Minimal traumatic surgery has to be done. Sometimes you can do pre-implant bone grafting to increase the size, where we do autogenous bone grafting. But if the patient is not ready, if you have any other option, better to go for short dental implants, which is better. If if there is a suspected fracture after we placed implant, either refer the patient or refer the oral and maxillofacial surgeon, or call oral and maxillofacial surgeon. So this is one case where the atrophic mandible has fractured. There are 3 implants placed. Because of the middle implant, probably the mandible is fractured at the symphysial region. So this you may not come to know intraoperatively. The patient will complain of some mobility, and then there is a possibility of non-union of the fracture. So it is very complex to treat because there is a compromised vascularization. In edentulous mandible, there is hardly any blood supply. In a dental mandible, we have endostic and periosteal blood supply, endosteal blood supply, and the blood supply given by the inferior alveolar nerve. Here, the inferior alveolar nerve is already collapsed. The neurovascular bundle is collapsed. There is no endosteal blood supply. So, and there is only periosteal blood supply, only for that area. So when you want to open that area, once you strip the mucoperiosteal flap, there is all the more no blood in the blood supply in that area. So that is why we use reconstruction plates. So the plates are longer and there is immobilization. The screws are not placed near to the fracture line. So that way we plan it, plan the reduction, because nothing can be done otherwise. You cannot use mini plates because this will go for infection, so, or non-union. So there are complications like non-union and osteomyelitis. So what we do is reposition and fixation with reconstruction plate, often combined with osteoplasty using iliac bone graft. So you have to add some bone in that area so that the healing is proper and the bone heals properly. So in very atrophic cases, we can use bone grafts where the bone is at lower level and the soft tissues are at higher level, especially K-wood 7 and 8, where the mandible has a negative base, means there is a prominent genial tubercle and high position of the floor. The floor is higher than the bone. So there we do augmentation procedures in the mandible. So preoperative evaluation of the patient and assessment of the underlying anatomy is extremely important. Prevention of all surgical complications is absolutely impossible. You cannot avoid complications, but obviously you can minimize. It can be reduced with appropriate treatment planning and adequate surgical skills. You can improve your surgical skills, call better person, learn from them, or particularly for that simple procedure, you can it's a complicated procedure, call the expert, learn, and then obviously stage wise you can do the procedures. Failure to recognize variations in the local anatomy of the maxilla and mandible can cause excessive bleeding intraoperatively, displacement, and malposition of the implant. So prevention of surgical complication actually means prevention of performing perforating vital anatomical structures. Very important is a lingual cortical plate of the mandible, mandibular canal, maxillary sinus, and adjacent teeth, where that is possible to prevent if you assess the patient preoperatively, clinically, and radiographically, or with CT scan properly. Patients should be informed preoperatively about dental implant procedure, including the risk of complications. You have to definitely take the informed consent, let the patient have signed informed consent, and then you proceed for the implant placement. Prompt recognition of developing problems and proper managements are needed to minimize intra and post-operative complications. So what is important is careful treatment planning, full medical and dental history, like the systemic diseases, bleeding disorders, anti-platelet medications, or if the patient is on blood thinners, we should know about it. Clinical examination, including palpation, very important, not with only mirror and probe. Wear gloves and palpate that area. Have a clinical judgment about the reach and the important structures around, and see, assess it, and then correlate with the investigations what you are doing. Preoperative imaging, so you can have local, you come to know about the local anatomy, and obviously virtual planning. 3D models and drill guides are definitely helpful in the complex cases. Understanding the individual situation and all potential problems is very important, and continuing education, training are imperative to acquire and maintain surgical skills. So what is the message to be taken home? Preparation is the key for success. So once you are prepared, there is a possibility of success, almost 99%. Do mind surgery before actual surgery. So once the surgery is planned, do that surgery multiple times in the mind. Always revise it, right from planning till the suturing and post-operative care, including the you have to tell the patients the instructions also. Very important instructions are there, especially when you are doing the sinus lift indirect also. You have to tell the important instructions, which we tell normally. In addition to that, we have to tell the patient not to do breathing exercises and all. If you forget that, and if the patient does breathing exercises, there is a possibility of implant getting sucked into the sinus without you doing any complication. It is possible because that area is very soft. If the surgery is planned after a long gap, if you are doing it, say, after 6 months, there is no harm in reading about the surgery, speaking about the surgery, discussing with your colleagues and friends, seniors. See the videos. There is no harm. You will get some idea. See the videos and plan the surgery properly. Most important, failures are part and parcel. So failures are going to happen. Complications are bound to happen. Keep the failure memory as short as possible. Don't just carry always that memory of failure along with you. Take help from others, but this memory has to be as short as possible. So they always say, old tradition in the Air Force, fly immediately after unfortunate crash. Do that particular surgery if there is a failure or a complication. Do that surgery as early as possible, immediately after that. That is a take-home message. Thank you so much for patient listening. That's it. I have completed.
Hello, sir.
Huh?
Thank you so much, sir.
Yeah.
If anyone have any doubt, please ask one by one by unmuting yourself. Yes.
बस ये हटाओ ना. Any questions? I am there.
You can also write your questions in the chat box if any.
Oh, Afyan madam is also there. Nice to see you. Senior people are there. Yeah, nice.
Yes, sir. We welcome Dr. Afsan Lazi, ma'am, President of IDA Mumbai branch. We are very lucky to have you, ma'am, here.
Thank you, madam. You're always there. Wherever I am talking, she's always there.
Thank you, ma'am. Thank you, sir.
Thank you, madam.
I request everyone to kindly on your videos so that we can take a screenshot. Please, everyone, on your videos.
I would be happy to answer some questions. Anything? Anybody? Dr. Anuradha? Dr. Kiran? Many of my friends are there, so I would be happy to answer.
Please, everyone, on your videos so that we can take a quick screenshot.
There is a question, sir, can we repeat the management of sublingual? I'll come to that. Yeah. You take a photograph.
Depends, sir. Please take a screenshot. So you can answer the question now.
What was the question? He wants to know about the management or mechanism. What happens? Like, what is his question?
Some management of sublingual hematoma.
Yeah. First of all, I'll come to the prevention again. Palpation is important. So you palpate the genial tubercles pre-operatively. Obviously you take a CBCT. With CBCT, you know where are the genial tubercles, and while reflection is important. Reflection, once you reflect properly on the lingual side and keep the retractors there as a protective mechanism, once you protect that area, then there is no problem. So this is a prevention. Now, if it has happened, and if this happens once you have nicked that area and there is a progressive hematoma formation, stop the procedure immediately. But obviously, you have to react fast. You have to see what is happening there. If there is a slow growing hematoma, you see the tongue is coming up and there is the elevation of floor of the mouth. Tongue is slightly going up. Just press that area. Bimanually, you can do that. One hand inside, one hand outside. Okay. If you have placed the implant already, and then you see that there is the base is getting raised, and the tongue is going up, and there is a closure of oral area, still you can do the same thing. Press that area hard so that further hematoma is will be in a less progress, like there will be less speed of bleeding inside. Okay. And those oropharyngeal airways, you just put one this thing, pharyngeal airway inside in the mouth, and just shift the patient. If it is progressive, then you have to act fast. It may be acting too much, like the doctor may say, why did you get the patient here? You could have managed there only, there is no problem. But there is no harm in keeping the patient under observation in a better setup. A dental clinic setup and a medical setup is quite different. So don't try to drain it out. Don't try to take the implant out. Just mechanically press that area. Make sure that you have enough time. If the patient is not able to breathe, if there is a change in the voice, that means it is dangerous. Keep the airway, place the airway inside the mouth. You can depress the tongue and press, and immediately shift the patient. Any other question? Are you satisfied, doctor? Whatever you asked me? I think, thank you so much, guys.
Yes,
you have appreciated. There is only one question right now. Is there any question? Okay.
sir. Thank you all the participants for patience listening. Thank you, Rajesh sir. Thank you, Tapet.
Thank you so much. Thank you so much.
Thank
Bye-bye.
you, Beach Mediclinic Private Limited. Thank you, Madhvi ma'am. Thank you, Afsa ma'am. Thank you.
Bye-bye.
Bye-bye. question I think Vasant sir has a question. Sir, I have noted down your question. I'll ask you, sir, and I'll answer you in your chat box, sir. Inbox, WhatsApp box. Sir has left, I think. Thank you. Thank you so much, ma'am. मैंने 19 लोगों को अपना भेजा है